Hi, Mike Gibson here, coming live from ACC 2023, and I'm joined by two guests, Marielle Scherrer-Crosbie, welcome, Marielle, and Tomas Neilan, welcome to both of you. And we're talking about the STOP-CA trial. This is the use of statins to prevent cardiotoxicity from anthracyclines. Tell me a little bit about what you did and what you found.
Scherrer-Crosbie, the floor is all yours.
Oh, thank you. So we wanted to test whether in patients with lymphoma who have quite a high rate of cardiac dysfunction and heart failure after anthracycline treatment, statin therapy could prevent or limit this cardiac dysfunction. And we chose atorvastatin 40 milligrams per day for a year in a randomized controlled placebo versus atorvastatin trial.
Now, Dr. Crosbie, talk to me about why you thought atorvastatin might help.
Well, there is a wealth of evidence that helped us make this decision. There are some experimental studies in animal models that showed that atorvastatin or statins decreased doxorubicin-induced cardiac damage and dysfunction. And then there are some retrospective studies that showed a similar finding. And finally, a small prospective study that showed potential decreases in LV function decline with atorvastatin.
Great. So you randomized these folks to kind of an intermediate dose of atorva, the 40, not the high dose 80, for a year. And what did you find?
Well, very interestingly, what we were looking for is a decrease in LVEF of more than 10 points to less than 55%, which is in the lower limits of normal. And we chose to look at the proportion of patients who would have experienced this decrease with placebo or atorvastatin. We found that in our atorvastatin group, we had 300 enrolled patients, and we found that 9% of these patients experienced this decrease in LVEF of more than 10 points to less than 55%, as opposed to 22% in the placebo group. And that was a significant difference that
wow,
we were
that's
able to
very marked. What if you look at it as a continuous variable, the EF drop as a continuous variable rather than as a threshold?
So we did that too as a exploratory point. We felt that it was more interesting to look at the proportion of patients, actually, as many of the patients with anthracycline, as you may know, have very little changes in their LVEF. So we felt that some patients who were maybe more at risk would be protected. And so that's why we chose our endpoint. So that's a great question. Actually, we did also find a difference between the atorvastatin group and the placebo group when LVEF was taken as a continuous variable, but this difference was quite small. It was about 1% difference. It was also significant. But it
was also significant, yeah. So is this ready for prime time?
Well, we certainly think, and I would also have Tom Neilan, who is, co-PI we're both co-PIs on this study, so he has to express what he thinks. I do think that, statins are, easily prescribed. We also have to note that we didn't find a difference in adverse events in our two groups. So that's important, in this population. So certainly, especially in patients in who we showed the big benefit, which were older patients, female patients, patients with high anthracycline dose, and that's important, and patients with high BMI. In those patients, certainly I would be very tempted to prescribe statins in patients with lymphoma getting anthracyclines, but maybe
Thomas?
No, I think Marielle, you said it perfectly. I think, one of the questions we've been asked now, Dr. Gibson, is how would you paint this to your neighbor? If your neighbor came to you and said, listen, who are the kinds of patients you would consider prescribing atorvastatin to? And I would say it's individuals who are over the age of 50. 52 is our mean study age. Individuals getting higher doses, more than 250 milligrams per meter squared. Individuals with cardiovascular risk factors, individuals who are obese. Those are the kind of individuals who seem to benefit most from the atorvastatin. Do I think that the average 24-year-old who unfortunately develops Hodgkin's lymphoma is going to benefit from atorvastatin prophylaxis? I do not. I think it's the individuals at higher risk. And I think that's the seminal message with the study, is that when you look at left ventricular ejection fraction as a continuous measure, it's only 1% difference between groups. That kind of impact, that would have no impact. If we were to present those findings, a 1% difference, people would say, great, statistically significant, but probably not clinically significant. But the proportion of individuals with a decline of greater than 10% was different. And that's the group that we're really targeting, the high-risk group.
Yes. Well, sometimes when you look at average reductions, it looks like 1%, but if you use medians and some other measures, it looks more pronounced. Well, I can tell you, not much of a downside to 40 milligrams of atorvastatin. It looks like a pretty big upside. So in the right people, this looks like it's a viable alternative. Well, thank you for your very careful science. I was not aware that this might be a benefit of statins. I'm fascinated to learn this. Thanks for sharing with us, and thanks to all of you from ACC 2023 for joining us.